I really was looking forward to chatting with you. I dig doing this. I appreciate you taking the time. So I guess
Likewise.
Thanks for having me on is the sort of tagline. But yeah, man, let's jump right in here.
Yeah, absolutely.
So I mean, the first thing that really comes to my mind, and this is the big question for me. This is the thing I have to ask myself a lot, is like, how much time do you spend right off the bat on just pain education? And I'll even couch that a little bit in the context of, as opposed to creating results-based buy-in.
That's a good question. It really it depends certainly on the person, and I try to get a read during the subjective portion of an evaluation, or even just sometimes like the initial email of saying like that they're interested in treatment. If I get somebody who gives me like a huge history, and that history is built around a structural context, if you will, a history of MRIs, history of treatment, I'm not going to try to break that mold too quickly in their head. I've just found too much resistance, and it ends up going farther away from good results. So I've learned that, and I know, I'm sure you're in the same boat. The more information we get on the pain science side of things or the biopsychosocial side of things, it can be, you sort of hear these buzz phrases from patients that are like alarms saying, ooh, this isn't good for prognosis if they start thinking too much in structural terms. But at the same time, I found is you have to tread lightly with that process of trying to over-educate on that and trying to pull people away from their thought process. It does need to happen, but I think you have to be gradual with it. So I try to just see, like, let me just get somebody moving and assess if I could actually, with movement, provoke a symptom, and then try to educate around the provocation of the symptom instead of trying to do it before there's anything practical that we're actually doing, if that makes sense. And that's certainly changed over time, where I might, as soon as somebody starts talking in the subjective in a manner that I think they're getting too deep into like a structural diagnosis, I might try to veer their thought process, but I try to do that less and less now, and just get people up and moving and have a more objective assessment going on. And then when I see, maybe based on their subjective, a movement limitation where pain is being provoked within a very specific portion of the movement, now there's more opportunity to educate and saying, okay, like, that pain may not indicate anything specifically structural. It might just be your body giving you a threat response. So we want to use that specific provocation of symptom in our assessment, and we're going to want to continue to use that. So it starts to veer the thought process around pain from damage to a usefulness in the process of their therapy.
That makes sense. I got you. So that's a little bit of the demonstration. That's let me actually feel this, so that have you feel this, so that we can unpack it. As opposed to like, hey, prepare for all these things we're gonna do.
Right.
We'll chat for 2 sessions, and then maybe 2 sessions in, we'll start doing things. Well, yeah, I definitely get that.
And one thing I would add to that is, it can be hard for patients, and I'm sure you've seen this, to actually describe where within activity they have pain. So pain just starts to become this identity that is, they're not actually even able to delineate the with what anymore of what causes the pain. It's just, I have pain, and when you ask them, like, all right, what brings it on the most? A lot of times I'll get, it's there all the time, or I actually haven't even really given that thought. It's just that there is just sort of this identity with pain. So it's really important for me to be able to delineate the with what, like really what brings it on and when and where, because that is very useful to me, but that should also help the patient to realize that maybe it's not there with everything. It's there with very specific things. So that becomes the process of starting to get people to see what they still can do, not just what they can't do, right? And the idea of what you can't do starts to, I think, creep in and become, again, more of an identity of like it's a comparison compared to what you used to be able to do versus actually like what is the real situation at hand. And I think that's why it's important to sometimes get up and start moving so that there is a more objective idea of what provokes the pain. And if you can find that in a session, I think that's huge for prognosis. If you have a hard time finding that, or if there's so much apprehension to movement that you can't really find that in the first session, I think that also speaks to the prognosis down the line, and the prognosis isn't as good.
But yeah, no, it's funny because the thing I think about, my sort of reaction to that is that idea of like getting the patient moving and getting them in the mindset of here's what you can do. Right. Because I find that, there's really a need to couch any level of education into like, here's what this means for you. Mm-hmm. Even to the point of, you were discussing like the patterns and getting patients to figure, like I've had situations where patients will go, a conversation will go like this. They'll go, it just kind of comes out of nowhere. I don't know what brings it about. And then I'll say something along the lines of, it's like a bucket of water. It's a lot of different factors. And when the bucket overflows, that's when you're going to feel the pain. That's why it feels mysterious. And then they immediately go, yeah, but I just don't know what brings it about.
Yeah, right.
And it just comes back to, okay, maybe I'll say that 10 times over the next 7 sessions and it'll sink in. But for right now, here's what this means for you. Because that's the only thing that's getting in there.
Exactly. Yeah, and I'll get on a similar note is, but what is this? We'll be going through all of the movement assessments, and people will be able to see what they can and can't do, and they'll really start to see progress too, like objective mm-hmm. progress in that they used to be able to do a lot less than they currently can do, but the pain is still there. It's still present. And more than anything, they just want to know, what is this? Like it's going to be one thing, right? Like mm-hmm. it's going to be a specific diagnosis. And I think that is part of just our medical model in general, that we tend to define things based on diagnosis and assume that those diagnoses are simple, kind of cut and dry. Mm-hmm. Like, they're just one thing. Like the body doesn't really work as a system of systems. It's just like, okay, there's some type of pathology. And once that pathology is clear, there's no connection to what caused that pain. So it's sort of like things are just, rolling through. And if you can just figure out the one thing that's going on, you'll be able to eradicate it and it'll never come back again. As opposed to it being more of a process-oriented thing, and that the body is just in a consistent state of dealing with relationships with the environment, the relationships of, the history of the person. So that's a gradual discussion. I think that has to be had with the patient, because that can certainly be overwhelming to try to tackle too quickly. But there is this sense of like, I need to know what this is, or I'm not going to get better. And that with the biopsychosocial idea, it's like you may need to feed that a little bit and just give them some type of direction of what it is in a way that would be useful. Maybe not feeding exactly their thought process from a biostructural standpoint, but giving them a sense of, a mechanical basis for why they might be having symptoms and how what you're doing can actually change that. And I think that's a tricky conversation, but it's necessary. And it's, I think one of your questions you were alluding to, does your patient need to be exactly where you are? And I don't think they do. I think you have to meet them where they are in many ways, and try to kind of meet in the middle by maybe veering them away from the idea that their pain is damaged, but at the mm-hmm. same time, not exactly, giving them the whole literature on pain science in one session too. You know what I mean?
Yes. Yeah, absolutely. It's an interesting scenario, because this may sound like a silly little metaphor, but like what is in my head is like this moment where, person eats something like super spicy and they kind of run up to you and they're like, I need water right now. And then now our job to go, okay, this is going to sound kind of weird because we need to develop trust, but you need milk. I know you're obsessed with the water thing. I know. I need you to trust me on this. Meanwhile,
Right.
their mouth is on fire.
Right.
And that is very much the spot I'm in now. I mean,
Hmm.
professionally, yes, because of my particular angle, where I'm at in the neighborhood, so to speak. But even within the practice setting I'm in now, because I'm very much in a practice where it's basically all word of mouth. And so the expectation that is developed in that word of mouth referral network is basically patient comes in. So here's a good example. Here's a good story. Youth athlete comes in. He gets hit from the right side. And the head clinician, the guy who built up this practice to his credit and is really good to his credit, is coming in here, and he kind of gives a quick look up and down, and okay, you're in this sport, and this is the thing, and then so patient gets hit from the left, and immediately he's like, oh well, yeah, this, and this happened because he got hit from the right, and then the compensation is this and that. And it's this quick, right off the bat, I know what thing needs to be put back in place. Meanwhile, he mentioned the wrong side. It's all based on the wrong event, but the patient felt so safe.
Right.
Because it was just this. Look, process in 2 seconds. I don't know what it is. Boom, I feel good. That's the expectation, right? It's this hyper reliance on, I'm going to put the thing back in place. And I know exactly which thing is out,
Right.
So not only am I pushing the milk, but I'm in a practice that's like got the big neon sign. We got the water that's going to that's going to make you feel better.
Right.
So there's very much the need to.
And I think the broad category there is confidence, right? Like a patient wants confidence from their practitioner, but I think you could show confidence in several ways, but let's just break it down into two major ways. You can show confidence in a way that sort of seems like you're selling something that's quick and simple. Mm-hmm. And then you can show confidence in your experience by saying that things are complex, and because I'm so experienced, I understand the complexity. So let me allow you in on some of this complexity, because you're in, especially for people that are in a chronic condition, I think it could be useful to allow them to appreciate that stuff is complex, and that might be why they're in a situation that is so chronic. It's not that people have continuously been misdiagnosing them. It's because the body is complex, and a lot of people are in chronic pain because of that, right? Mm-hmm. So we, and that I think could come across in a confident manner, right? As opposed to just being like, oh yeah, I've seen this before, I know exactly what to do with it. Well, you can say, I've seen this before, but I've also seen this similar presentation play out in several different ways, because people are very variable, right? And patients are very variable. And I think that helps in kind of making that bridge between, going away from just something being structural and something needs to get put back into place versus something that really you need to embark in a process. And I'm going to help you, educate you on that process.
Right. Absolutely. And, it's funny. I find that where I am in my career now, the headbutting that goes on with me is that, I want to demonstrate the confidence of this is an ambiguous experience. It is your individual experience. I can guide you with that experience because I know how to do that, but we are going to tackle this meaningful experience you're going through. We are going to work through this. And the confidence that the patients want, with the expectation, the word of mouth expectation that has been set, is the confidence of a guy who's going to come in and know exactly what to do right away. So many of I feel like a lot of the questions I sent were some manner or another of expectation. What do you do with expectation? It is so much about expectation.
Yeah.
Because to your point of meeting in the middle, there is this sort of need to provide, to an extent, the confidence that the patient is looking for. It's that
Right.
like where to land on the spectrum of chameleoning to the patient versus providing to them the service they need.
Right.
Because I very much have gone the other way with that. Like I certainly have made the mistake of going, I will develop trust with you. We will do that. But for right now, in order to trust me, you need the manual therapy. You need structural approach. Let me do that and wean you off it. And I have made the mistake of bringing the patient to this point, a few sessions in of okay, yeah, that's cute, all your stuff with the pain, but I'll see you in a month and you'll do the rubber dub on my back again. I've steered too heavily into that, and gotten them to that place by accident where they go, yeah, he says also this stuff about some pain or whatever, and then I go in and I get worked on, and then he puts some stuff back in place. So it's definitely a very careful tightrope walk.
Yeah, and I think it matters how much time you typically get with somebody and what your model is, right? Like your clinic model, right? And that's my clinical model has changed over the years based on the place that I'm working at, and now having my own practice, it's been easier to adapt to the way that I want to treat and the way that I find best to treat. But at the same time, it's not the best for everybody, right? And I'm going to be missing out on seeing a lot of people, or maybe as many people, just because of the current model I have. But one thing I would say is, like, because I get to see people for longer periods, because I have like a hybrid practice that goes into personal training, and I might be seeing people, and I've been seeing people for 5 years plus, that's a different process than having a clinical model where somebody might come in once a week, even 3 times a week for only like 6 weeks. Like they're all different processes that you have to sort of triage and prioritize differently based on the model. And you'll start to see certain people that you're just going to have to maybe give them something that is less ideal than you think it should be, just because the clinical experience doesn't allow for any more. And I think at that point, it's important to say, like, if somebody is looking for maybe manual therapy, for instance, then you just give them the best manual therapy you can with, education that they need in that process. Like, I think it's okay to do that sometimes, especially if somebody is seeing multiple people, which I get a lot of people like that, where they might be seeing, a chiropractor for a specific purpose, right? They might be seeing a massage therapist or body worker for a specific purpose, and then they're seeing me for a different purpose. I see a lot of clients that are seeing another physical therapist for a different purpose, or they might be going through insurance with another physical therapist and seeing me like less frequently outside of insurance to get a different experience. So I have to take all of that into account and not try to force like the same thing on every person, right? Because like if somebody is not getting manual therapy from their other therapist and I have more time to give them one-on-one time, I might shift into manual therapy with that person just because they're getting they're getting more of the therapeutic exercise somewhere else 3 days a week. And I can maybe assess more things in the time I have with them because I have more time to be one-on-one, and vice versa. If I have somebody who's getting all types of hands-on from other practitioners, then I probably won't touch them with my hands because it's overkill in many ways, unless I really just need to do that specifically to get at, an assessment of what my active interventions are going to be. So I think all that goes into play. And if you just have a scenario where somebody, like, that's all they view you as is the manual therapy person, I think that could be okay, depending on who else they're seeing and what other type of education they're getting.
I would certainly agree. I would certainly agree that I think it's easy to get dogmatic about approaches, or in this case, dogmatic about not using approaches. I think it is sort of easy to get lost into the rabbit hole of like, I better not ever touch anybody, or else they're going to get addicted. Which I don't think is appropriate. But you make an interesting point of, it's okay to be the manual therapy guy if they're seeing other people, they're getting needs met, they're getting exercise, somebody's taking them through a strength program, whatever it may be. It's interesting. The idea of scheduled manual therapy is an interesting topic to me, and I don't know why that's so different in my mind than massage therapy.
Right.
Because for some reason, if you tell me you get a massage every week, I'm thinking, okay, stress gets high, you're taking care of yourself, you're relaxing, you're heading to that little med spa, whatever it is, but if you tell me you're getting manual therapy, I don't know why then I go like, oh, every week, dude? Like, I don't know why that's so different for me. I think it's because I'm coming from the bias again of like, I'm inappropriately associating that with like, dude, are you getting somebody, are you having somebody put stuff back in place? Like, and that's not always the case. That's not always what's happening. But I'm so used to that world. I have this like Pavlovian response to it.
And I hear you too. And ironically, I just listened to a podcast today on it's the Physio Network's podcast, and they had a researcher that I've read a lot of his stuff over the years, Dr. Chad Cook. I think he's at Duke University, and he studies a ton of manual therapy interventions and all of the context around that. And one of the things he was saying was that, there's a lot of myths around manual therapy, but not many of them are founded in much, especially in the idea of them becoming like a patient becoming dependent on them. There's not a lot of evidence that that's true. And the other thing that he connected to is that a lot of interventions that we do in the rehab professions, not just physical therapy, but anything where we're trying to change people's pain or change people's function through non-invasive means, a lot of them have the same effectiveness if you actually look at the evidence, right? So something even like TENS and electric stimulation has pretty decent evidence behind it for making changes. So that's where it's like, you don't have to bias yourself against one or for one, but like just understand where they all fit, because certain people will get different benefits for them. And then the clinical situation will change in such where you may just feel like, oh, it's best for me to use this skill for this person. Right. So it doesn't seem like any evidence would refute using manual therapy, but it also doesn't say that it makes changes structurally. So I think like a lot of times where you and I both agree, but many of us will take it too far, is that manual therapy doesn't make the structural changes that are theorized. However, that doesn't make them ineffective at all, right? It's still effective, but they're more pain modulators than they are structural changers, if you will. So, and then that's where people start to say, well, it doesn't do what people were theorizing that it did, so it's not useful. But those are two different things, right? And I think we get lost in theories in the movement professions a lot, right? And then as soon as a theory doesn't pan out, we get rid of the intervention. But the intervention kind of always worked. That's why we started studying it and theorizing around it, is because there was this anecdotal experience of improvement that we kind of can see clinically, but we then have to put a theory around it, from a more structural or a biomechanical standpoint. And oftentimes those don't pan out because the human organism is maybe a little too complex for the theory. So we just end up throwing away the intervention, even though the intervention actually works. It might just work for a different reason.
Well, you know what, man, you bring up a to my mind, a very fascinating point here. It says like, now we're getting down to like, the Joker in Gotham City. Now we're getting down to like burn it down, because like, I'm going to be a little flippant because obviously there is a difference between active and passive interventions. So obviously there's a categorical difference there. But you make an interesting point, which is that like we know that the evidence is fantastic for the benefit of exercise, but not that there's really not much evidence that exercise is, again, changing much structurally outside of strength for actual strengthening, outside of getting more into what you're starting to do as a PT on the back end of, these programs. There's not much evidence that you're actually changing scapular dyskinesia or and so, it's this, hey man, well, you know what? I can just take that Occam's razor there and turn it right back on. If it's contextual effects, who's to say I can't set up that good context for the TENS machine? Just have this patient, like you start to untie the knot a little bit, which I like the, I like the poetic metaphor of that. Like, hey man, it's all context. Getting, to... Well, like I sometimes do, up on your high horse about exercise versus manual therapy, that kind of thing.
Right, and I think that's a different conversation when it's around pain and it's around symptoms than it is around, say, just movement efficiency in general and movement for performance. Like, I think they're all slightly different conversations that do fit in a spectrum or a continuum with each other. Right. So if you don't have a symptom, I think in some ways the conversation around ideal movement mechanics gets a lot trickier. When you have a symptom, it's less tricky because the symptom can dictate what's best for that person in that moment. Right. Like being able to work around a symptom and use a symptom as your indicator of what's good for that person at that point. But then when you don't have a symptom, when you're in this sort of injury prevention world, there is a lot of arguments that come up as like, why are you picking this particular posture over another posture that you're going to promote as good technique or good form? And I think in many cases, you just have to have a why for what your starting point is. And there are a lot of different whys. So if you look at the different movement models, I think it's important to find the common threads among the movement models instead of looking where they're all different. Because if it wasn't different, then there wouldn't be more than one movement model, right? So in order to sell a movement model, you have to make it somewhat different. But as a student, right, like I think it's important to find where they're the same. And then that's where you start to find like a good starting point for where you want to move people toward, or if you're having some type of postural assessment or some type of movement assessment, just to get a sense of what people can and can't do, right? And not judging it as like good or bad, or this is going to be damaging or not damaging, but just seeing, like, having maybe a theory in your own head that you're working with, that if somebody can't do something, then maybe down the line that's going to be the thing that gets them, right? And then if a symptom comes on, I think then the provocation of symptom takes precedent, and that gives you even more information about what might be something that you want to work around or work away from a movement standpoint. Does that make sense?
Yeah, it does make sense, because, if you boil it down to the things that are common to all these techniques, that does give you the freedom to then tag on whatever talking point the patient needs in that moment. Wherever you're trying to get to, you've got all of this freedom to say, well, this is going to be a less antagonizing position. This is going to be less sensitizing. This is going to be, whatever it is. And, it allows you to kind of walk down that continuum you had mentioned before of like, we've started with this expectation. We need to get to this one. I've got a lot of wiggle room in these very common approaches.
Right.
Yeah. Yeah. No, so that definitely makes sense.
The question I was going to ask you, and I know when I was in school, and this is back in, I graduated in 2006, so it's been several years now. I remember just the chiropractor versus the physical therapist. There was a lot of animosity there for some unknown reason, but it was like just steeped even into our formal education process. And I think a lot of it was just based on these different theoretical structural principles of how we treat. And, you know, as I've gone through different continuing ed courses, I've just seen, like, once that theoretical structural model sort of goes away, and you look at it more from a, you know, biopsychosocial model or something along those lines, you realize that we're really doing very similar things, right? Like, so the scope of the therapist and the scope of the chiropractor is not that different. And in many ways, that's the term for my company, Movement Professional, is sort of based on that, is that we're just all, like, the broader the term, the better. Like, we're all movement professionals, whether you're a body worker, whether you're a physical therapist, whether you're a chiropractor. What did you get in your education as far as, you know, the way that things were talked about with scope of practice?
So it's interesting. I went to New York Chiropractic College, which for years billed itself as a little bit more the medicalized chiropractic option. I think that when I graduated, I was seeing a trend of kind of going a little more middle of the road, you know. But from that kind of institution, we definitely were given the idea of this chiropractor as primary care physician. You know, we were given this, not gatekeeper, but, you know, like, we're the first eyes on the patient. You know, maybe you're the only guy who's going to see this guy's back. So if you see the mole, you're that guy. Or, you know, you have to be able to do a real medicalized physical exam, because maybe the guy doesn't even have a primary doc. You know, it was
Right.
it was a lot of it was definitely a lot of emphasis on, medical cooperative, which I like, because, you know, that's not always a given with chiropractors.
Right.
But I would say there was maybe a little too much emphasis on, like, hey, you guys can be primary care physicians.
Right.
And I don't want to come off as any kind of certain way, but, like, if you don't do something else post graduation, if you don't further your education down that rabbit hole, no, you're not, dude. Like,
Yeah.
you know what I mean? But that, yeah, we were definitely taught to a very large, wide, broad scope.
Right. I think that's actually a really good point. And when I was in school, it was about that time where one, physical therapists were transitioning over to, like, everybody was going to be a doctorate of physical therapy. So I was, like, one of the last master's classes at University of Scranton, and then I went back and got my doctorate. And now you can't find a non-doctorate physical therapy program. But that also started to veer the curriculum more towards being a direct access practitioner, is the way that we call it, not necessarily like a primary care type of a practitioner, but somebody who can see a patient for physical therapy without a doctor's prescription, or without initially them seeing a physician. And that sort of became more of the education, which I didn't think it was a bad thing, but it seemed very like geared towards just, like, promoting the profession instead of looking at where are we as physical therapists, like, where are we actually best suited to be, right? It was almost more like we were trying to become more like physicians as opposed to being better versions of ourselves, if I could, you know, put it that way. And, you know, going back and, like, being a therapist for now, like, 15 years, I realized, like, we shouldn't be anywhere near physicians. Like, they have their own thing that they do, but we are, like, much better than their field at the things that we do. Right. And, like, to try to, like, maximize that, which would be looking at movement, having the time to look at movement and where pain and injury fits within a context of movement. Right. Like, that's just, in my experience, like, not part of the physician education. Theirs is the structural model, the biostructural model, because it kind of has to be. Like, they don't have the setup, they don't have the time to take people through movements on a scale for weeks or months, and actually see how their body responds and how the pain behavior changes with movement. So that's where, like, that should be our job. And I just feel like the idea of making us more of that primary care physician took a little bit away from like what we could do best.
Yeah, I 1,000% agree. There's a lot going on with this idea, because what it seems to me is that like the healthcare profession at large is in the same place mentally that patients are, and that
Mm-hmm.
is that pain in itself does not rise to the level of importance to be considered its own diagnosis, right? Like
Mm-hmm.
pain is
Yeah.
not meaningful because it's pain. It has to be that somebody has a joint has degenerated, or
Mm-hmm.
arthritis in there, or a muscle. It's like it's not sufficient to say your pain is meaningful, because pain sucks, dude. Like that's why it's meaningful. You know,
Yeah,
I,
exactly.
I I think there's a version of that that the healthcare industry itself needs to learn,
Yeah.
because I think it needs to be that, like, dude, we're the pain guys, and that means a lot because pain
Mm-hmm.
is wacky. Like we're the
Yeah.
pain guys, and that's high up because pain is a weird thing to treat.
Right.
And like the other, I think that bridges the other thought in my mind, which is that I almost feel like pain is inappropriately treated in sort of a medicalized context.
Right.
I think from what has been impressed upon me in looking at like the pain science as I best know it now, is the way, like, what pain-based care really is what life coaching purports to be. You know, and that sounds a little space cadetian out there, whatever it is, but like that is why pain is weird, because it is all encompassing. You
Mm-hmm.
can't just say, I'm going to relax this muscle. I'm going to pull this bone chip out of there. I'm going to give you this artificial disc. I'm going to inject this. You know,
Mm-hmm.
no, man. It's everything. It's an
Mm-hmm.
ink that has leaked its way into everything. You know,
Yeah.
and again, like, yeah, man. What do? I only treat pain, and that means a lot. You know.
Right. Yeah, I'd agree. And I think the way I like to look at pain, especially chronic pain, I think there's definitely a difference between pain that is associated with an obvious recent trauma, right? And I mean, I think the literature would show that as well, where it's just like the treatments and the prognosis is just much different when there's like an obvious, more recent trauma that you can deal with, because you can then start to think of things a little bit more structurally if you just know that something has been structurally damaged, like right in front of you. Like you can pinpoint exactly like where that came from, like a sports injury or like a fall. I think those are different things to look at when you're looking at pain. But most of the pain that we would see clinically would be chronic pain, you know, pain that's longer than 3 months, certainly. Just because it usually takes that long for people to start to think about doing anything about it. So, you know, clinically we are seeing mostly chronic pain. And when you look at that, I think you have to look at chronic pain as sort of like a sixth sense. Like it's another sense, but it's a threat sense. So it's not this, you know, again, specific anatomy thing. It's more of just like vision can come from your eyes, but vision isn't specific necessarily. It's like it goes through your brain, and you need the brain to see just like you need the eyes to see, right? You need the brain to smell just like you need your nose to smell. So like you can think of pain then as this sixth sense, this other sense of a threat response coming from the whole body. And your body will respond to that in different ways. But if we start to equate pain more as threat than as damage, that I think is very useful, but doesn't make it simple. It certainly makes it more complex. So then we can then look at anything at a certain point that is threatening. We have to be able to change that threat response for people. And I find movement and exercise is a very objective way to do that, because you can start to objectively show people they can do more than they thought they could, but that just takes time, right? So strength training for me and for a lot of my clients is just demonstrating to people that they can lift a weight, right?
Yeah.
Not how much weight that they're lifting, is that they can bend over and lift a weight, whatever that weight is. And then when they realize they can, then they are gradually, progressively increased. But like it may take months to over a year before somebody actually hits like a plateau in strength, so to speak, because like a physiological plateau in strength. Like if you are an athlete, right, and you're going into a kind of strength and conditioning program, you're going to get tested in some way for what your physiological limits are, like your 1 RM, your repetition maximum, or some version of that. And you'll get that pretty quickly, just because you're going to base a lot of your programming off of those limits. Well, with somebody who is not an athlete and doesn't want to be an athlete, or has a history of pain, or is actually coming in with pain, you may just be demonstrating to them that they can do the things that they didn't think they could. And that your gradual progression may take so long that they never really actually touch anywhere near their limits, like their physiological limits, because it's a psychological limit that you're trying to move through. But it's objective progress. So even if it's slow, and you're allowing them the control and how quickly they want to progress, it still gives them a sense of, oh yeah, I'm better. That doesn't mean you're taking their pain away, but you're showing them that they can change. They're not what they originally thought they were. And I think that's really important in the chronic pain world, because threat starts to go down, because at least the initial thought of what this pain was and how it was going to limit them, it has been disrupted a little bit.
Right. That is absolutely my favorite thing to do. And that's what I love to do so much. At Life Clinic in Lifetime Fitness in Fort Washington, is, people would be downstairs with me in the clinic, and they go, hey, okay, cool, I'm coming in for you to make my pain go away. And then I get to go like, great, let's go upstairs. I bet you didn't see that coming, but let's go upstairs. Yeah, that objective walking toward, hey, look what you did now. Look what you did now. Look what you did now. Like, it's such a, I don't know, it's just fun. It's such a fun process.
It really is. But it is very objective. And I think it turns this binary idea of like, I have pain or I don't have pain into more of a sliding scale, or like a volume knob instead of an on-off switch, where somebody will maybe start to develop pain after a certain amount of work that is done, right? And it might not be during, but it might be after a session. But this is all stuff that can be discussed and put into context. So now it doesn't look like I just have pain, or I have pain when I lift from the ground. It's I have pain when I lift from the ground 35 pounds for 10 repetitions, but not 8, right? And that's a huge difference. And to just see everything as a spectrum, and then really you're like I feel like my job is to right away get to the thing that people don't feel like they want to do or they don't think they can do, and have some type of plan to deconstruct the movements that they currently fear, so that they can do some version of that as quickly as possible around their symptoms. And if that's if that happens, now they are in the process of changing, right? And they may move to the point where they don't have pain with that movement within anything that they decide to train, or certainly within function, which would be staying outside of any like specific exercise program. Or it might just be that they at least know that they're training some version of that thing, even if they still have problems with it functionally. And that keeps them as close to in the game as their pain will allow them to be. And I just think that that's much different than just looking at something from a structural joint by joint diagnosis, where it's like, this joint has to change, or we can't even touch that movement that you're afraid of.
Yeah, and I mean, and the beauty there too is, even if they're not yet in a place where they can trust that it is not some patho-anatomical thing, even if they're not ready to let go of the anatomical threat, in that case, in that scenario, you've still increased movement freedom within that envelope. Now added this family of things we can do. Okay, cool. So you're still a little worried, but here's this whole new branch of things we can do over the next month. Let's add this other, and just slowly walk that line. Right. With or without the sort of, buy-in of, I'm ready to say this isn't a disc, or whatever it may be.
Yep. Yeah. Absolutely. Yeah. And I would say, like, in the model that I have, and this kind of goes back to what we were talking about before with manual therapy, like passive versus active interventions. When my sessions start to look more like personal training, the prognosis is better, right? And just because we're getting into that idea of seeing how pain fits into like a broader context of movement, where if people are coming to see me from a just for like that manual therapy side of things. Not that that's not useful, but I think they're certainly farther away from the end game, if you will, if that exists, right? They are, their prognosis is just not going to be as good. So as soon as it looks like that we're training sort of when they're coming in, like we're going through circuits, we're taking them through movements. It doesn't have to be as isolated to specific joints. That's a good prognosis. But a lot of times, like even early on, that can take hold, because when you do full body movements, and I think in many ways it's easier to work around pain as opposed to working specifically at the joint where the pain's coming from. There you have to be much more cautious. So when you work full body, you can just change range of motion. You can do a ton of different things to regress the movement to work right around pain, and then people are getting more movements as a whole system early on, and the more that becomes the thing that they want to do, and that we're using that to actually mark their progress, the better the prognosis is.
Absolutely. Back to that point of buy-in. The more you can accomplish early on, the better everyone feels. And even in terms of that idea of like, compensation is always a bad thing, but even that positive compensation, again, look, you can press a little bit more through the left arm than the right, and suddenly you can put those Christmas decorations back in the attic, or whatever it is.
Yeah.
You kind of twist it a little bit over that right hip, and then suddenly you can give the lawnmower a good little pull, whatever,
Right.
Absolutely. Just the utility of compensation in those whole
things. Yeah, because we'll have it, and it's, when you're training on a more regular basis and seeing progress with that, you also start to just notice the nature of some of these fallacies that you might have heard, right? So people will start to notice their natural asymmetries, and it will start to go against this notion that you have to be symmetrical, or your body's going to break down. And it brings up the conversations about symmetry. Is it normal or natural or somehow possible to be completely symmetrical? So I find that ends up when people are in a mode of training, like these questions and answer sessions become easier to come by, like the education on pain and the education on some of these sort of postural fallacies that are out there. They're easier to have just because they're bringing them up themselves as they're noticing different things. Like, and that, like, as somebody who trains yourself, right? Like if you train yourself, anyone that I know that's in fitness, that's at a high level, like no one's walking around with perfect symmetry. No one's walking around and has never been hurt before, right? Like, and no one does the same thing all the time either, right? Like people are figuring it out. They are exploring. And that's sort of, in my experience, what makes a good fit person or a fitness professional is they're always like curious and exploring what's going to give them certain gains within a certain intention too, right? And then they'll be changing their intention frequently. So as you're in that training process, as your client or patient gets into that training process, they start to think more like fit people, like healthy people. And then you're able to have conversations with them, use your education to kind of take them farther in that process, which again, just moves people farther along in the overall process that you're trying to get out of them.
Yeah. And absolutely. And the overarching theme with all of this, again, is you're changing mindset. You're changing the view from which you're looking at this thing,
Right.
And that is by proxy, like physical stuff is changing. But again, it comes back to this weird kind of almost kind of life coaching, because that's really what you're doing, to look at it from a different angle.
And I think life coaching is just another one of those like scope of practice terms, right? Like is a personal trainer a life coach? I think it just depends on how often you see somebody, right? Like if I'm seeing somebody, several times a week for years, then I have a part in coaching their life, right? Like I don't have to call myself a life coach, but I have a big part. I have a bigger part in that than I did when I was in a clinical setting, just seeing someone for 6 weeks at the most. Right. So like, I just think, we're all if we're movement professionals helping people move forward physically, we are some version of a life coach. So that might be the broadest term you can use for, what we do. But I think it matters how often and how long you work with someone, the relationship you build with someone over time. So, I think it's exactly what you're saying makes a lot of sense. It's just another one of those terms that can be used very generally.
Yeah. Right.
Mm-hmm.
And I mean, one of the things you mentioned a few minutes ago, you said people are always experimenting and nobody's walking around in a gym setting and has never gotten hurt before. Like that's just not, I don't, that
I'm
is
aware
probably a young guy, a not very strong guy, but it's definitely not somebody experienced in that setting for sure.
Mm-hmm. Right.
And with this whole idea of looking at things from a different angle, that really makes me think about the conversation of pain relief versus pain resilience. Mm-hmm. Because that's the journey, I feel like I'm taking my patients on. I've definitely heard everything from, maybe somebody who hasn't been in a few months, the chiropractic office, and they go, yeah, man, I really needed to come in. I was running the other day and I felt this weird thing in my ankle. It's gone now, but like, I want to get it checked out, everything from that to somebody coming in and going, yeah, I don't know, man. Like I felt like there was something in my shoulder the other day, but it's fine. It came and went, and whatever.
Yeah.
And everything in that spectrum,
Right.
Because it's without developing that pain resilience, I definitely feel like I see people who come in and they go like, to paraphrase, and not to be too much at risk of being too much of a smart ass here, but like, people coming in and you go like, I had an emergency. I like a 2 out of 10 pain for like 7 minutes. And I really want to make sure, the real, therapy is getting to that point of like, okay, this is what pain is. It's no big deal. It's going to go away.
Yeah.
Nothing's broken.
Yeah. Yeah. Let's use your pain. Let's make it useful. You know what I mean? And I think that's a big part of making it less of a threat. So, the more that the education can move away from that something is being damaged, something specific is being damaged internally, to there is a threat. So you want to listen to the threat, but you also want to understand that you can make the threat more of a threat by just how you think about it, the context around it. And that's a slippery slope to try not to make it that it's all in the person's head, because that's, that's like old terminology, but it's only old to people that are in the health and fitness industry. It's, the things that we kind of take for granted being in a, health and fitness profession are going to be 10 years advanced and then some from the people that we see. Right. So a lot of what we think of as old notions are brand new notions to our patients and clients. So we have to really be cautious with that. And I find that over and over again, like, whether it comes about things with exercise, nutrition, is that some of the things that like you'll never hear anymore in the fitness or health world because they're so obsolete. Like concepts are still very much fresh in the general population's head, right? So the language that you use, just that you have to be careful with that. But I think just being able to gradually veer the conversation away from structural damage towards a threat response is huge. And then it becomes, okay, how can I use my pain to change what I'm doing, right? Because we're always trying to make a change in a patient or a client's outcomes or presentation, but that change isn't going to be like it's there and done, right? Like to make it look a little bit more like change is always happening. We're just involved in veering your change when something that you're feeling is limiting you, right? So like being able to just guide change instead of like eliminate a specific problem that will never come back, or if it comes back, then it's a failure or something like that.
Yeah. Yeah, and that's sort of that's the dirty little secret. Like in the back of your head, you don't tell a patient on day one. They're like, make my shoulder pain go away. Make it go away forever. In the back of your head, you're like, I'm not going to do that. When we're done with 100% success, you're still probably going to have shoulder pain to some point again before you in the rest of your life. What I'm going to do is sort of change how you think about it.
Right.
Like if you say that day one, good luck. Have fun never seeing that patient again. But that's the thing. You're like, when is the appropriate point to let you in on the little secret that I'm mostly changing your reaction to the pain, and your change in reaction will make that pain both less frequent and also less intense.
Yeah. And I think that's where getting people moving and then starting the education process really is helpful, because you need that pain provocation information as a professional in your assessment, right? So you really need to ask questions about it, really delineate the pain behavior. So as you're doing that, it becomes an opportunity to educate the patient on why you need that information and what it is and what it's not, right? It doesn't have to take away from any biomechanical discussion either, right? Because when you're trying to get the pain behavior, you have likely a biomechanical idea in your head of what could be possible, and that there's no reason not to explain that to your patient, especially if they are looking for something along those lines, right? That's why we have our anatomy skeletons in our clinic, and we have our mobile pelvises. I find that to be super helpful for myself and for patients. But we know it's not only that, but that could be really helpful to say, well, this is what I'm thinking when you're telling me that your pain responds this way to this movement. And that can change if I move you this way. So the key is to just demonstrate that the pain can change, right? If somebody has an idea of arthritis as an unchanging phenomenon, that their prognosis is going to be a lot worse. So using terms like arthritis or something that's more of a chronic condition that's supposed to be kind of unchanging or progressively worsening, we have to get away from that because it just gets in the way of any thought process that something can change for the better. But making the model more of when we move this way with this type of control and you get this particular symptom, this might be happening, at the joint or around the joint. And if we move in this direction or we control the body in this direction and we get less of that pain, this is what's going on. That can be useful, I think, those anatomical biomechanical images inside the person's head. You're still trying to get them to move in the way you want them to move away from pain, but it might be helpful to have that image in their head, which isn't so distant from what they're coming in thinking about.
Yeah. And I love that idea of reframing what the patient is already saying, reframing what the patient already is hypothesizing. Because one of the things you had mentioned was what we take for granted is usually far ahead of what the lay population has, and sometimes bridging that gap is difficult. And compounding that complexity is the fact that when we are struggling with something we don't understand, all we really have are these societal tropes. All we have are these archetypes, other people's stories. You know what I mean? So if there's any level of ambiguity, I'm going right back to, Gary had pain and he said it was his disc, or, if I'm missing something, well, in your head is a thing. Okay, you must be saying it's in my head, because those structures already exist. I got nothing to do but to grab onto that, and so it becomes so important to I'm going to take your thing and I'm just going to tweak it a little bit. Let's just give it a little spinneroo here, and this is really, you know what I mean, so that we're not saying abandon that, throw it in the dumpster, adopt this new thing you've never heard of before.
And
it's the beauty of, again, turning degenerative change into age-related change or whatever it may be, that kind of stuff.
And dynamic versus static, right? Dynamic change, things are always changing, you know, just based on, you know, time, but also body position, you know, different pressures in your body, like allowing people to get the idea that they are able to change is so important, right? And that speaks to the, you know, the psychological principles that tend to show positive outcomes. Like if you are fixed in your mindset, your outcomes for so many things are down compared to if you have more of a growth mindset, or the locus of control, like internal versus external. Like if you think you can change and you're in control of your own change versus that you're dependent on someone else for change, it seems to be your outcomes will be better based on, like if you have more of that mindset that you can control your own change. So we have to be part of that, you know, that way of directing people towards that mindset, which, you know, I'm sure there's some genetic, you know, things with that too, right? Like we might just not be able to change everybody's mindset, because mindset, personality, they're very deeply ingrained in genetics, but also just, you know, experience from day one in life, right? So that's just something to appreciate. Like you can't change everybody. So that's again where you have to meet people where they are and do the best you can for them, and not try to force any ideas. But if somebody doesn't have an idea of that something can change, then I don't know why they would be seeing you. So somewhere down there, they have to have that mentality, that it's possible. But, you know, people might just be going through the motions too, because a physician told them to go to physical therapy, right? And if someone's coming in with the idea that there's nothing they can do in physical therapy that would change a structure, and, you know, until they get surgery or something, then they probably are going to need surgery just to break out of that mentality to say, okay, now I got a new structure. Now let me start fresh, whatever, you know, at least in their head, fresh to move forward with some type of movement intervention. And sometimes that's what's necessary.
Right. Right. I mean, I got nothing to add on to that, because that's perfect. That's 100%. You know, I will say I love, you know, there's so many good metaphors I love, and I think Greg Lehman has a fantastic one when he's talking about context, and he talks about guy coming home from, I'm gonna butcher it and shorten it, you know, but guy coming home from work, and you know, it's been a good day, so his kids are going crazy. He's able to kind of, you know, hey, peacemaker. Crap rolls downhill a month later, you know, as it inevitably does. Comes home after getting reamed out, and kids are going nuts, and it's a screaming match. You know, it's just such a perfect. You know, so, look, man. Sometimes it's going to be a good day. Sometimes it's going to be a bad day. Right. You know, sometimes you're going to have slept last night. Sometimes you're not. Sometimes you're going to exceed the tissue's capacity. Sometimes you won't. You know, Ben Cormack has the one with the cup of water, right? Like, dude, a lot of stuff goes into the cup. It's not just like pour in disc herniation. Right. It's thousands of things, you know. And I think those are just really great ways to, you know, dude, the water's going to go up, it's going to go down, man. It's like when it goes up, it's coming back down again. That's the same side of that coin. Right. Yeah.
And there is no doubt that communication plays a huge role in your ability to connect with your clients and patients. And oftentimes the communication of what the research says is not very useful. Right. But it's so fresh on our heads, because that's what we're looking at, that it happens all the time, right? Like where we go to that, where it's like, well, this is what the evidence shows, you know, trying to use that to change people's minds. But analogies oftentimes work a lot better. Right. Because they will put something that is already in their head into a context of what they're experiencing now, as opposed to trying to have to believe something that's not their field. Right. Like it's not even like about believing what the science says or what you're saying. It's just, it's not speaking their language. They're not in the research. They're not thinking along the lines of research. They're just thinking along the lines of what's ingrained. Right. So I think when you can take something that's already there, like an analogy, like that's very well understood, and then make it make sense for their current experience, it's so much more valuable. But, you know, experience will allow you to do that. Listening to other people that have those analogies is useful. you ever read Painful Yarns by Lorimer Moseley?
I've not read Painful Yarns. I want to check that out. I want to check those stories out. I know that book, and I really need to pick that up. Yeah.
Yeah. I mean, in a lot of their work is metaphor oriented, right?
Yeah.
And even like Explain Pain, there's so many metaphors in there that are really quite useful. Painful Yarns is just like a book of metaphors, pretty much a book of stories. But in there, he even, they're basically case studies. Like he even talks about some people it just didn't work for, right? Like, he used the whole metaphor that he basically wrote a book on, or a chapter of a book on, and it just like went right past someone, because that's not what they were, were looking for. It was, and that's part of being a clinician, and that's what's different about being a clinician than, say, a scientist. Is a scientist doesn't have to have those conversations and see how those conversations affect your outcomes, and how it's going to be so different for different people. You can do scientific research on the value of metaphors, but you're not necessarily going to be able to figure out what metaphor works for every situation based on science, right? So like there's always the need for clinician experience, and then when you start to notice stuff like metaphors and how you communicate really matters, well, let's study and see if we can find common threads to it, but it'll never be like protocol oriented, because people are so different.
Well, I'll tell you, man, you really make me chuckle with like the utility of hitting patients with research.
Yeah.
Because if there's one piece of advice I could give any new practitioner, it is nobody cares about research. It took me way too long to learn that extremely important point. Like I'm going to date myself a little bit. Do you remember, Chris, the original Jurassic Park movie?
Yeah, absolutely.
Do you remember that scene where they're meeting at the restaurant, and the one guy's treating this like a spy movie, and he's got his like hat down and his sunglasses, and the other guy, he says his last name and he yells, hey, we got this guy here. Yeah, nobody cares, dude. Nobody cares.
Right.
That to me, that's one of my favorite moments in any movie, because man, I got to that point of like, oh, you don't give a crap about what I'm talking about, and again, it comes back to, you have to make this you have to put this in the context of, how can I use this information right now? So, okay, you're blah blah blah, but how can I take the sentence you just said and use it right now? Or how has this person, how are you speaking to like the identity of this diagnosis, or this person in the context of the pain? If you're not speaking to one of those two things, identity or like pragmatism, dude, nobody cares that in 2006 Johnson et al. Found whatever.
Right. Yeah, absolutely. And I think the other thing is if somebody is in the context of moving and progressing objectively with physical activity, then sometimes people are just they're gonna have their way of talking. And this is something I've certainly learned, where it's like, you don't want to try to butt in the way that somebody talks and try to change the way that they're thinking about stuff, unless it's getting in the way of their progress. Right. And especially with training, I've learned this. I have a lot of, female clients that the way they think about exercise is that it's about, losing weight, spot training, different areas. And no matter what, I've had the conversation many times, like they're going to go to that line of thinking, or, and I see this quite a bit too, is that they're just very hard on themselves. Like if I'm asking them to do something, I'm giving them a guide, but say they're feeling a little fatigued and they can't do as much, like, that's fine. I don't get upset about it, but they get more upset about it than I do. Instead of trying to like always, break that line of thinking or that line of talking, just as long as they're in the program that I'm giving from, they're showing up and being consistent, I think it's okay to let them have their narrative. It's when the narrative gets in the way of progress that it becomes a bigger issue. Or when a conversation's already taking place and you can have, a deeper conversation with somebody about maybe how that terminology can lead to things that aren't positive over time. But if it becomes this thing where you're just constantly like correcting people, then you can kind of become a dick, right? And then it's like, that's not helpful either, right? Because that's part of, like, when you look at research, like, a lot of times you can become this contrarian because you're hearing things that are against the norm, or against, like, the normal way of thinking about things in society, or even the normal way of thinking about things within the profession, because that's why we do research, to check on some of the intuition that might be going on in the field and seeing if it's correct or incorrect. And most likely you're going to find some way of adjusting a certain intuition, right? So you can constantly be that guy who is just pointing out, no, that's not in the research, or that's not right. Or you can just sort of, like, let it play out and just make sure that people are objectively progressing. So I think it's important to separate those things out sometimes.
Yeah, isn't it? That's really interesting. It's like a clinical narcissism. It's like a clinical version of that. Like, actually, guy.
Yeah.
Like, you don't want to be that guy.
Yeah.
And I can imagine a world in which you're very well-meaning, trying to develop trust by going, look how good a hands you're in. I know all this stuff, and so you can and, like, I can understand where the well-meaning version of that is, but you end up just turning into this contrarian of just I remember seeing a thing that was very contrarian like that, like, science myths, and, like, one of them was hey, coffee doesn't dehydrate you. Don't, stop saying that coffee doesn't dehydrate you, which is technically true. But then, like, you could see this thing, like like espresso's not going to dehydrate. Like, that's going to contribute to, and it devolves into, well, it depends on how you brew it and how much. Okay, well, then it does depend. Like, stop being so contrarian.
Right.
You end up in this nitpicky very place.
Exactly. Yeah. Yeah, absolutely. And I think that can happen, especially when, like, new information is fresh in your mind, right? And then you hear something that sort of is against what you just heard. It's like you want to spurt that out, because you want to have conversations with people about what you learn. And I know, like, the people I see the most, other than my family, are my clients. So sometimes, like, they get the worst of me because I'm trying to, like, basically share my new knowledge. This new information that I got with them, and it they're not ready to receive it or willing to receive it. So, I mean, I guess that's just part of a client-patient relationship, or a professional, client relationship. But yeah, I think it's definitely something to consider. I've experienced that, and the feeling is very specific when I've gone too far with that, where it's just like, it feels like awkward, as opposed to it feels like a conversation that is leading to more, like, branches, more threads, right? And sometimes I have great conversations with my clients where, like, I'll bring up some new information, and then they bring up their experience, and that becomes more of the session than the exercise sometimes. And I think there's some breakthroughs in thought. And the longer that I'm working with people, the more those happen. But if I'm just, like, sort of nitpicking on, like, maybe a personality trait that I see that I have read that won't be good for their progress over time, I have to really pull back and sort of be silent, and just focus on what I want them to do. You know what I mean? And I think I think the same thing can be said with, like, people's attitude towards pain, is that as long as they are objectively moving and being compliant with the physical things that you want them to do, and you're seeing some change with that, you don't have to nitpick on all of their thought processes around pain.
Yeah, I think that is where, for my self-discipline, it's very important for me to choose what is the one thing I need this patient to keep in mind when they leave here, because that allows me to kind of pare down that instinct and go, okay, you can believe it's coming from the disc. You can believe your posture's bad. You can believe that, sitting all day is just invariably a bad thing for you. But you're leaving here not afraid of the pain. You're leaving here understanding that intensity does not indicate danger. If that is true, I'm satisfied for today.
I think that's awesome. And I think that's the idea of just, broadening categories. I think that's huge to and it's necessary for people that aren't in the field, right? Like we can get really specific with how we categorize like new information, but we have to be able to broaden that in a way that makes sense, which is similar to creating analogies around it. Just like finishing the book that I wrote, and I had like a chapter on pain. I wanted to do that as much as possible. I wanted to make things as broad as I possibly can, and just to make it for both practitioners and the general population. It was a tricky thing to do, but I found like that statement of pain does not equal damage is probably the most important thing that I would want to get out to any patient, even day one. And just, then we can go from there for what that means. But just that whatever your MRI, your X-ray says, that's fine. Like it's not useless by any means. It's just, it doesn't equal your pain. Like they're not the same thing. It doesn't mean that it's not related or in any way. It's just that we can't say that they're the same thing. Nobody can say they're the same thing. So if we can get that across, then I think like so much now opens up. Because if pain does not equal damage, or the damage you have does not equal your pain, now we actually have some opportunities to change it. Right. Absolutely. And we also don't have to be as afraid of feeling pain. If it's more of a signal of threat than it is actual damage, then every time you feel it and exploring it won't become some type of threat response in itself. It'll actually be something that is useful.
Right. Yeah, because God, I've had so many patients come in, and the subtext is, I'm here today because I want to know what my prognosis is. I'm here because I'm afraid that when the pain starts, I might be making something worse. I don't want to do that. I don't want to be the 76-year-old woman hunched over. I don't want to create a fracture somewhere where I don't want to tear a muscle. And it's basically like, tell me whether I can move or not. That's pretty much what they're saying in that entire opening sort of interview, and then from there it's like, well, we've just done 40% of the thing, because you can move at home. I'll see you next time.
Right. Yeah. And I have over the last decade or so, I've really gotten into, meditation, mindfulness, and even I started with getting into Buddhism to get me into those practices. And there's so many principles there that I actually have to be careful not to jump into. It just like we can go too much on the things that are like common sense to us and assume that they're common sense to our patients. That's sort of how I feel about some of these like mindfulness principles now that can be very foreign to a good portion of people that aren't in a practice along those lines. But when it comes to chronic pain, like everything that you can glean from a mindfulness practice will help chronic pain. It's just, it's a practice. It's not something that's like a drug. So I have to be cautious that I don't go into that well too deeply too soon, because it's something that just like is intuitive to me at this point, but it's not going to be, it might be like very foreign for some clients, and it might have some type of religious undertones that, people aren't ready to touch, right? And it might offend some people. So, but when you just look at things along the lines of how people look at the nature of things being dynamic or changing, and that's what we're trying to get out of people. We're trying to get this idea that your pain is not permanent because of some type of permanent damage in your body. Well, that is built within the concept of impermanence within Buddhist meditation. And so, like, I'm trying to basically get those principles out without making them sound, metaphysical or spiritual or something like that, because I just think they're so deeply ingrained in what we're trying to get out of people from chronic pain or any type of really like psychological process.
Right. Yeah. That, and the only thing I can, I guess, commiserate on that, because I'm not as well versed in mindfulness as I should be. And I mean that, like, I definitely, Well, I'll circle back to that, but the way that I can connect with that, is this idea of information overload, or this
Mm-hmm.
idea of um, um, just things that the patient is not ready for.
Mm-hmm.
When you're when you're just used to operating at a certain level, it's definitely, if you're used to, like, operating on that sort of 8 out of 10, it's easy to accidentally, like, hey, good to meet you, come here and meet me on this
Mm-hmm.
6 out of 10. We'll trickle a little bit at a time. We'll give you the whole and that's definitely something to watch out for.
Yeah.
That curse of knowledge, definitely.
Right.